Hello, my name is Katherine Lopez. I am a paramedic and educator for the Denver Health Paramedic Division. We will be covering essentials in wound management in a disaster setting. Full disclosure, the Mountain Plains Regional Disaster Health Response System Just-in-Time Learning Series is funded by Award Number 6, HITEP 2043-01-03 from the Administration for Strategic Preparedness and Response, ASPR. The content of this presentation is a product of the individual presenters and does not represent official policy of the United States government. This information is not meant to be a substitute for professional medical advice, diagnosis, or treatment. I have no financial interest or relationships to disclose. We will be discussing the purpose of wound management, TCCC concepts we use in a civilian setting, recognizing and treating life-threatening hemorrhage, emergent wound management, and further treatments. The risk of becoming injured is high in a disaster setting. This includes mass shootings, floods, chemical hazards, and fires. Appropriate wound care with simple measures can reduce mortality and morbidity. Our priority in the disaster setting will be to first preserve life and limb as best we could. We can then promote healing and prevent infection with the hope that complications will be minimized. A lot of our methods of wound control are taken from concepts introduced in the military's Tactical Combat Casualty Care, also known as TCCC. This includes the methods we will be focusing on today: controlling massive bleeding, applying basic wound care, and addressing hypothermia. Additional casualty care issues are addressed after life threats are taken care of, including pain control and the use of antibiotics to prevent infection. It could take as little as 3 minutes to bleed out, so it is imperative to stop the bleed as soon as possible. The first step is to quickly identify any significant bleeding. Here's a diagram from the Defense Health Agency, illustrating some common examples. Starting from the left, pulsatile or steady bleeding, any extremity amputation, overlying clothing soaked in blood, pools of bright red blood on the ground, and/or ineffective makeshift bandages soaked with blood. If a patient has a superficial wound that is not hemorrhaging, it is okay to leave it open for it to heal. This avoids subsequent infection. Once we expose and identify where the bleeding is coming from, we want to apply direct pressure. This cannot be done if the injury is to the thorax or abdomen. These regions of the body are non-compressible. This diagram, taken from the Homeland Security Stop the Bleed campaign, shows the first 2 steps to take in order to control bleeding. Apply pressure, preferably with both hands. Consider pressing the extremity down onto a hard surface to gain better control. Apply same sort of pressure even when using bandages or clean pieces of cloth. Do not use excess gauze or clothing as it will make the maneuver ineffective. If manual pressure stops the bleeding, keep the dressing in place. If bleeding is not controlled, or if the bleeding is obviously massive or deep, we will want to immediately apply a tourniquet and/or pack the wound. Tourniquets can only be applied to extremities. We can also apply wound packing to extremities if a tourniquet is not available. On the left are some commercial tourniquets approved by the Committee on Tactical Combat Casualty Care. Wound packing can be done to the neck, armpit, or groin. Keep in mind, if using wound packing on the neck, you do not want to occlude the airway. Hemostatic gauze takes about 3 minutes of direct pressure for it to work, whereas regular gauze takes about 10 minutes. If using fabric, tightly woven absorbable cotton is preferred. Athletic fiber will not work, as it will wick moisture and not absorb the blood. Applying a tourniquet is a time-sensitive skill that must be done rather quickly. Therefore, it is important to have it easily accessible. It is best to use a commercial tourniquet rather than an improvised one to make sure there is an appropriate circumferential compression being applied. In this case, we are using the Combat Application Tourniquet, otherwise known as CAT. Place the injured extremity through the loop, 2 to 3 inches above the bleeding site directly over the skin. It is preferred to expose the extremity. Direct contact with the skin avoids possibility of it slipping. If clothing is difficult to remove, do not delay placement of the tourniquet. Use your best judgment. Placing a tourniquet over a heavy jacket or insulated pants may not be effective. We should never place a tourniquet over a joint. If we are not sure where we should place it, we will use the high and tight method. We will place a tourniquet either below the shoulder joint or hip joint, respectively. We will pull the strap and fasten it all around the arm, but not over the rod clips. It should be tight enough so the tips of 3 fingers cannot slide below the strap. The strap should be fully tightened before tightening the windlass rod. If we can slide our 3 fingers below the strap, we will need to retighten and resecure the strap. Next, we will twist the rod until the bleeding has stopped and place the tip of the rod into the clip, locking it into place. If bleeding has not stopped, or if there is a distal pulse, we will need to apply more circumferential pressure by winding the rod. If we have another tourniquet available, we can place it above the first tourniquet as seen in the diagram below. Reassess and make sure there is no distal pulse and that the bleeding has stopped. Route the rest of the strap between the clip and over and under the rod. Do not leave it hanging as it can be pulled off when moving the person. Secure it with a time strap and record the time it was successfully placed. Distal pulses should not be felt. A properly applied tourniquet will cause excruciating pain. Do not release it. Releasing the tourniquet can cause more damage and can lead to death. Verbally relay the time the tourniquet was placed with the team that will take over the person's care. Tourniquets can be in place for up to 2 hours without significant ischemic injury. Those left longer than 6 hours will more than likely need an amputation. A question that comes up quite often is the use of tourniquets for children. Most commercial tourniquets were designed for the adult. However, there are studies showing their efficacy when using them on pediatrics aged 2 to 16 years old. The Pediatric Trauma Society supports their usage despite limited research. There is no data supporting the use of improvised or manufactured tourniquets for toddlers under the age of 2. Let's review the common mishaps in tourniquet placement again. These involve time, location, tightness, and the use of a second tourniquet. Again, it could take as little as 3 minutes for a person to exsanguinate. If unsure where to place a tourniquet, high and tight is best. Never place the tourniquets over joints. Another common mistake is to not fully tighten the strap before tightening the windlass rod. We should not be able to slide 3 fingertips below the strap. A loose tourniquet can cause compartment syndrome, adding on to more complications. And lastly, place a second tourniquet proximal to the first if bleeding has not been controlled. Never loosen the tourniquet after bleeding is controlled. Superficial pressure will not be adequate for large, deep wounds. In this case, pack gauze tightly into the wound and hold pressure until the bleeding stops. This can be done to extremities if a tourniquet is not available. Do not remove the gauze once bleeding has been controlled. Never remove an impaled object. In disaster settings, impaled objects should remain in place. Stabilize the object with gauze rolls or tightly wound pieces of fabric. As a side note, the only reason to remove an impaled object is if it interferes with CPR or if it is compromising the airway. Sucking chest wounds can be recognized if there are air bubbles coming out of the chest wound when the person breathes, or if there is a crackling sound on the skin surrounding the injury. In this case, place a vented occlusive dressing such as an Asherman seal directly over the wound. An improvised occlusive dressing can be placed as well by using a piece of plastic or even a glove and taping down 3 sides. This prevents air from entering the chest wall during inhalation while allowing air to exit during exhalation. To do this, wipe down blood and debris from the chest wall. Apply the dressing during expiration directly on the wound and reassess. The person will have to be monitored for worsening signs and symptoms such as shortness of breath, distended veins around the neck, and unequal chest size as they are breathing. This could be due to a clot formation around the injured site, which will not allow for the air to exit. In this case, the dressing has to be burped. To do this, remove the dressing, wipe down the area, and allow air to exit. Then reapply the dressing. For eviscerated organs, lay the patient down with knees flexed. If warm, clean water is available, irrigate organs to remove debris or other contaminants. Gather the organs and place damp dressing over them. They should be kept constantly moist. Cover the damp cloth with impermeable plastic material and tape all sides. Do not force the organs back into the abdominal cavity. The primary goal of the burn injury is to stop the burning process. First and foremost, identify and treat any hemorrhagic bleeding. Remove all clothing and any jewelry due to subsequent inflammation. If chemical burns are suspected, irrigate area with copious amounts of water in a safe zone. Dry chemicals should be brushed off before applying water as they could cause more injury when irrigated. Both thermal and chemical burns will need the area to be covered with a sterile sheet. Further cover the person with blankets to prevent hypothermia. Keep the person warm. After life-threatening wounds have been stabilized, clinicians can provide appropriate pain control. All wounds in the disaster area are considered contaminated and will need antibiotics to prevent infection. And lastly, keep the patients warm as hypothermia interferes with wound healing. Here are the references used to complete this module. Thank you for your time. We hope this module has been helpful in assessing and treating wounds in a disaster setting.